Thank you very much, Marita, and thank you so much for making the time to come here today. It's amazing to see so many people here thinking about exercise and oncology. So I'm absolutely thrilled to have the opportunity to meet you and to have a chat today about our work, investigating the role of exercise for the management of cancer. So what I wanted to do this afternoon is just take the opportunity to have a chat about what we do, discuss our research very briefly, and then also have a quick chat about the future directions, what we're hoping to achieve in the coming years. So what do we do? Well, as an exercise physiologist, I use exercise as a medicine to help manage disease and improve both the health and the well-being of patients. Now, to realise the therapeutic benefits of exercise, we require and we use very targeted prescriptions of exercise based on the physiological changes required to improve health. Now, exercise improves the structure and function of many of the body's systems simultaneously. And in fact, there's virtually no medicine or therapy that can influence positively as many body systems as exercise can simultaneously. Now, the physiological changes and understanding the physiological changes behind exercise allows us to be very prescriptive with how we use it. And we can prescribe exercise much the same way that doctors prescribe medicines or therapies. And by using this approach, we can be very targeted with our prescriptions. And we can make sure that these prescriptions are very specific in terms of the type of exercise, the volume, the intensity of that exercise, based on the mechanism of action and the dosage that we require of that medicine. So our research focus is really to apply exercise as a medicine in specifically managing cancer and talking about not just the prevention, but also the management of adverse effects of both cancer and its treatment. So we really aim to improve and enhance the lives of people with cancer by designing and evaluating interventions that improve their physical, mental and social well-being. Now, our ultimate vision really is to have exercise incorporated as a standard component of cancer treatment. And in order to do this, I suppose our goals are twofold. It's not just about generating knowledge that helps us be very prescriptive with this medicine, but it's also about translating this evidence into practice and improving the services that are available for people with cancer. So if we were to do this, what would it look like? So for every patient, we would want to have an actual prescription of exercise medicine. And it's important to have a prescription coming from the oncology team because it really brings clout to the use of exercise as a medicine, and it helps convince patients to take it as prescribed. Now, if we were to use this prescription, what would it specifically look like? Well, based on the evidence-based guidelines, we want our patients to be working to achieving a combination of aerobic exercise and resistance exercise. And this is really important that we get it at the right dosage so that volume and intensity is appropriate. So it's not just doing the gardening or walking your small dog, it's walking your German Shepherd at a moderate intensity where your heart has to pump a little bit and you're sweating and you're breathing hard. In the same way with resistance exercise or lifting weights, we don't want you to be able to sit there and lift weights while having a chat to Betty sitting next to you. You really have to be working hard and working up a sweat. I think really importantly, what we need to do as exercise physiologists is individually prescribe our exercise. So it's tailored to each person's specific health status and it's progressed according to individual responses. And that's really important. Because this is how we actually start to personalise and target this exercise prescription. And when we're talking about patients with cancer, and this is very lofty, or these are very lofty goals, but we really need to have a tailored, targeted prescription. And this targeted prescription needs to be specific based on the cancer type, the stage, the treatments patients undergo. So an example of this may be what we use for men with prostate cancer who are undergoing androgen deprivation therapy. We have a very rapid loss of bone mineral density, and we use a specific type of exercise, this impact exercise, to stimulate bone remodelling. Now, this is obviously quite sophisticated, and the guys here make it look pretty easy, but it's something that's very different than what we'd prescribe to a lady who's got bone metastatic disease secondary to breast cancer. So it's really important that we're not just, or that we're moving beyond these general exercise guidelines, and that we're actually tailoring and targeting our exercise prescription. And this really comes out of what we do with our research, not just us, our team, it's a field in general. So generating knowledge so that we can specifically target these exercise prescriptions to each patient. So what I want to do now is just give you a kind of overview of the research that we've been doing. And I'm happy to share slides, so don't feel like you have to write everything down. I'll go pretty quickly through this. But most of our research, or the majority, really focuses on men with prostate cancer. So men with prostate cancer undergo a range of different treatments, and these treatments, while very effective, as you can see here with a 93% survival rate, lead to pretty debilitating side effects. And these side effects contribute to a lot of burden, especially when you consider the amount of men who are being diagnosed with cancer, prostate cancer, and are living for a long period of time. So it's I suppose, a growing population with very unique healthcare needs. I think one of the most distressing, persistent, and probably problematic side effects is sexual dysfunction. As you can see here on the slide, up to 90% of men with prostate cancer experience some form of sexual dysfunction. And as you can see in the slide, men with prostate cancer experience sexual dysfunction at higher rates than any other men with chronic disease or men with erectile dysfunction. You can see here this is a problem that's not really being addressed with our current management strategies. About 50% of guys report unmet needs around sexual health, and these needs are probably the highest level of unmet needs, and this is reporting based on an Australian sample here. So it's not really surprising when you start to look at the etiology of sexual dysfunction following prostate cancer treatments. It's a bit of a laundry list of everything that you don't want to happen as a bloke, I suppose. But the relatively direct effects of prostate cancer treatment, specifically of surgery and radiation, on actual erectile functioning are quite well known. And we understand that these can be rehabilitated through penile rehabilitation strategies and pharmaceutical medicines. But sexual dysfunction and sexual health is a multidimensional health issue, and there's a vast range of factors that contribute to diminishing sexual well-being in men with prostate cancer following their treatment. Things such as body feminization, rapid loss of muscle mass, gains in fat mass and a female pattern weight gain, fatigue, physical fitness declines, which is then augmented by psychological distress, depression, anxiety, emotional lability. All these things, if you like, come together to have a bad cycle of sexual dysfunction for men with prostate cancer. Now, there are strategies to help counteract this. As I said, the pharmaceutical strategies, but they don't really take into account all those relatively indirect effects that contribute to sexual dysfunction. So we propose that exercise may be a new therapy to address some of these indirect factors. And while I don't think that exercise will recover changes in surgery, changes from surgery or scarring from surgery, there's a range of relatively indirect effects that exercise has established efficacy to counteract in men with prostate cancer. So to counteract that body feminization, to energise the men, counteract the fatigue, to help manage mental health conditions, and also to help men increase their masculine self-esteem. I mean, prostate cancer is a highly emasculating disease, and certainly something that men of the age that we see most men being diagnosed with don't really handle quite well. So to have an evaluation of this, or the first look at can we actually see exercise, if exercise does improve sexual well-being, we conducted analysis on a randomised control trial of almost 60 men with prostate cancer who are undergoing androgen deprivation therapy. We used a 3-month supervised exercise program involving both resistance and aerobic exercise in a group-based setting supervised by accredited exercise physiologists. It was twice weekly resistance and aerobic exercise sessions, and we were looking at sexual activity, a self-report by the men of sexual activity. And this is what we found. So you can see here, for sexual activity before the exercise intervention, men in both the exercise group and the usual care group had the same level of self-reported sexual activity. After the 3-month intervention, the blokes that were in the usual care, not receiving any exercise, decreased their sexual activity, and the exercise acted to maintain the sexual activity with men who were involved in that supervised program. We saw that it was really driven by changes in sexual desire, and the men that were actually exercising were maintaining or increasing their desire in sex. So this is really important because it gives us a first look at, hey, exercise may be a new therapy to help manage sexual dysfunction. And we did see with this study that those changes in sexual activity were actually related to the changes in quality of life. So we're starting to think about, hey, do these factors actually, are they reflected by those relatively indirect changes that we talked about earlier on in terms of the etiology of sexual dysfunction? Now, to unpack this a little bit, we asked the guys what they thought, their perceptions of how the exercise program influenced their sexual health. So this was a qualitative analysis of 18 guys. And these were guys who were involved in an ongoing supervised program with us, as you can see here, an average of almost 4.5 months. And we did a thematic content analysis using an interpretive phenomenological framework in order to gather what kind of the experience or lived experience of these guys were, specifically relating to how exercise potentially influences sexual well-being. And what we saw is that the guys were reporting that the exercise acted to help reinforce their sense of masculine self-esteem, and that contributed to improvements and their perception of improvements in sexual well-being. And when we unpacked this further, we started to see what was driving this increase in masculinity. And you can see here these changes are the things we were talking about earlier on. So counteracting body feminization, the guys actually having a better perception of their body image, energising the guys to counteract that fatigue, counteracting psychological distress and improving their mood. And then things about, giving them, reinforcing their masculinity, allowing them to engage and master an activity that is masculine and reinforces their masculine values, as well as a sense of control, something that they could actively do to fight against the sexual dysfunction. So we've moved on from this and really looked and proposed an intervention that we're actually trying to evaluate exactly what it is about exercise, or is exercise an effective way to manage sexual dysfunction in men with prostate cancer? And what is that? What drives that? What's the cause of that? So this is an NHMRC funded trial that we'll be running here in Melbourne that we'll bring over. It's actually it's a 3-arm randomised control trial. So we have guys who are exercising versus guys who are exercising, and we're combining that with some basic psychosexual education. So it's very easy for the guys in terms of their self-management. It's things talking about intimacy, medical management of sexual dysfunction, stress management, and so on. And we're comparing that to guys who are doing no intervention whatsoever. So with this, we're looking at sexual well-being as an overall marker of sexual health. And we're then starting to unpack all those areas that the guys have previously talked about contributing to their changes in sexual well-being, and trying to understand exactly what is driving changes in sexual well-being. So we're running that trial here in Melbourne, hopefully sometime soon in the new year. This trial is really about thinking about and proposing and evaluating an integrated treatment model. So if we go back to thinking about that multifaceted etiology of sexual dysfunction, we can't just have pharmaceutical therapies to counteract those relatively direct effects. There's a whole range of other things that we need to counteract. Can we use exercise to counteract those physiological side effects that aren't really accounted for by the pharmacological therapies? And then can we add in some very basic psychological intervention to counteract the other psychosocial factors that are contributing to sexual dysfunction? The idea really here being, can we propose something that is accessible to men, that men will engage in, that can be affordable for men to actually start to counteract and counteract sexual dysfunction and meet this unmet need. So to shift gears a little bit now, I just want to talk about our work looking at counteracting the adverse effects of androgen deprivation therapy. This is a mainstay therapy for men with prostate cancer. It's locally advanced and advanced. What this does, it takes testosterone levels down to castration levels quite quickly. And you can imagine taking testosterone out of a man's body does a raft of different things, and you can see here some of the changes, especially in body composition, bone health, what that means in terms of risk of comorbid conditions, metabolic diseases and bone diseases. And then, all the things that I've kind of touched on already: fatigue, declines in functional capacity, sexual well-being and psychological distress. So previously, we've used exercise to actually try and rehabilitate these side effects once they've been established. So once guys have been on ADT for a set period of time, it may be a matter of months, up to 6 months, a year, and we start to rehabilitate, dig them back out of the hole. What we wanted to think about here is, can we concurrently prescribe exercise when ADT is prescribed to prevent some of those side effects from happening in the first place and minimise the adverse effects of androgen deprivation therapy? So this was a randomised control trial involving 60 men who again involved in group-based, accredited exercise physiologist supervised exercise intervention involving resistance and aerobic exercise. And we were looking here, can we actually prevent those changes in body composition that occur very rapidly following the start of ADT? So this graph here shows the changes in body composition, and what you see with the exercise group, you can see these first columns here are looking at that fat markers there. So the exercise group's actually not gaining fat, and we're seeing a trend towards them losing some fat during this initial 3-month period of androgen deprivation therapy. And the change between those two groups is significant difference. So we can actually say that exercise in this way, when it's concurrently prescribed, is minimising gains in fat during this initial 3-month period. You can see when we get to the muscle mass markers here, they were both decreasing, even the guys that were exercising. That wasn't a high enough stimulus to counteract the negative effects of androgen deprivation therapy, but there were trends and certainly a significant difference here between the groups in the fact that the exercise attenuated the loss of muscle mass during that 3-month period. Now, when we looked at a range of secondary outcomes here and looking at a number of those factors around the side effects of ADT, we saw some pretty positive effects. The exercise was able to generate improvements in strength and fitness for the guys during this initial 3-month period. You can see here attenuating the decline in sexual dysfunction or sexual function, which was statistically significant. Prevented fatigue and psychological distress from coming during that first 3-month period. And you can see here some differences that weren't just statistically significant, but clinically significant in terms of improving their mental well-being and their social well-being. We also looked at a range of blood markers here. It didn't budge prostate-specific antigen, PSA, or testosterone, so it didn't interfere with the effectiveness of that treatment in terms of counteracting the spread of prostate cancer. But we didn't see any changes in a whole range of metabolic blood markers, blood lipids, and we even looked at bone turnover markers as well. We didn't see anything change during that initial 3-month period. So we're building on this, and we've got a trial we've just closed enrolment to, but it will continue ongoing over the next year, funded by Cancer Australia. We're really building on this work and saying, can we actually extend this and look at the intervention over a longer period of time, over a 6-month period, and can we incorporate in some impact exercise, like the ones that I showed you before, jumping, skipping, to really stimulate that bone growth or minimise the loss of bone during that initial ADT period. So this is really, again, can we start to prevent, or can we actually prevent many of the side effects that occur from ADT with a concurrent prescription of exercise medicine that's tailored, that's targeted, and that the guys will actually engage in. So stay tuned in the next couple of years for those results. Moving to the other end of the spectrum, guys with advanced prostate cancer. These guys, as you can see here, have a much poorer prognosis. It's when the cancer is spread to other areas of the body. It commonly spreads to bone. And you can see here that not only do the guys experience a lower survival rate, but they have a vast range of morbidity. It's associated with long-term ADT use and also skeletal complications from that cancer actually degrading away the strength of that bone, causing pain, and also causing things like pathological fractures and increased risks of spinal cord compressions. So this, as you can imagine, has a pretty large impact on everyday function and quality of life. What we see in the literature and what has happened in virtually all other research is that these guys are actually excluded from exercising. So it's a risk-adverse recommendation that we don't want these guys to exercise because we don't know if it's going to be safe, we don't want them to break bones. But we don't really do this. If you think about an athlete, if an athlete gets injured, if they hurt their leg, it's not like they stop exercising, they just don't use that leg. So we take this same kind of approach. Can we actually tailor and target the exercise that it avoids the areas that have bone fragility so we can maximise our safety and still give the guys some exercise so they can counteract those negative side effects of their treatments. So this was really the first foray into using exercise to help counteract side effects in men with bone metastatic disease. There's only a small trial funded through the Cancer Council WA, a randomised control trial with 20 men over a 3-month period when we used a modular resistance exercise program. So what that specifically means is that we looked at where the bone lesions were and actually avoided those regions. So if, for example, someone had a bone metastasis on their rib, We didn't do any upper body exercises that would stimulate or affect that area, but we would do lower body exercises. And we did this, and that can become hard when you have people with widespread disease, but it's a metric that we were able to apply across all these guys. Really importantly, as a first foray into this, what is the safety and feasibility of resistance exercise in these guys? We saw that there was no adverse events in terms of the guys who were actually able to do the exercise. They were able to do it at an intensity that was in line with what we would prescribe for guys with localised disease or guys that didn't have bone metastatic disease. If you have a look at this compliance value here, this was basically, the guys were able to do what we specifically prescribed for them each time, or 93% of the time that they were turning up for their resistance exercise. So it's not only a metric or a matrix that could work, that the guys could actually do in theory, but they can implement it in practice. And you can see we had no change in bone medication throughout the 3-month intervention. And I should say that this is, we screen these guys very specifically before we start. So it's not guys that are having a huge amount of symptomology, so they don't have significant pain in the first place. They may have a low level of pain that doesn't impede their ability to do everyday activities. So we were still able to get these guys exercising, and they were able to benefit from this exercise. So this graph shows us that the guys who were exercising could exercise at intensity that allowed them to stimulate physiological adaptations. They improved their muscular strength. They improved their fitness. They were able to walk faster in this instance. And the difference between the guys who were exercising and the guys who weren't exercising, they were able to gain muscle mass or not lose muscle mass. And these changes, I think, have really important implications in terms of preventing skeletal fractures or skeletal complications moving forward. I think really importantly as well, what we see here, this physical activity level, this was low intensity or mild physical activity that was specifically measured using an objective measure, an actigraph, so an accelerometer. So some people might think, especially if you have an exercise background, who cares? It's mild exercise, it doesn't make a difference. We want them to be exercising moderately. For guys with advanced prostate cancer, I think this is a huge outcome because it tells us that these guys are actively able to engage in their life more. They're less encumbered by the disease, and it may be a marker of actually showing that they're less fatigued by their disease as well. So I think a really positive outcome in terms of this first little look. When we followed these guys up 6 months later, we saw that some of these changes were sustained. So after they finished that supervised program for 3 months, we followed them up after that, and we saw that, as you can see here, the muscle mass gains remained, functional changes remained. They were still able to maintain their level of low intensity physical activity that was objectively measured. And they reported having improvements in quality of life in their physical domain and also the physical domain of fatigue. So I think that this is really promising results, and indeed we're building on this with a trial funded through Prostate Cancer Foundation of Australia to see how can we actually implement this practice in line with those best practice guidelines. So incorporating not only resistance exercise, lifting weights, but aerobic exercise as well. And the idea here is really to counteract those long-term effects of treatment that the guys have been on for a considerable amount of time and to maximise their function and well-being during their, the years that they have left. Another element that's really important in prostate cancer is mental health issues, and probably not talked about a lot. So 1 in 8 men will be at risk or will be diagnosed with depression. The rates for prostate cancer are almost double that. Okay. The guys with advanced cancer, locally advanced and metastatic cancer, have 2 to 4 times greater risk, 2 to 4 times greater risk of suicide. So these stats are really concerning, and I think as you can see down the bottom that almost half of guys report unmet psychosocial needs. It's a really important area that obviously our current management strategies aren't effectively targeting. So we've worked with PCFA and Suzanne Chambers to actually push forward the agenda for using exercise as a medicine to help manage and prevent distress. And certainly in the model that we've proposed here, for the ProsCare model through PCFA, is actually incorporating exercise as a part of universal care for the prevention of distress. And this is a tiered model, so as you have more and more distress, you actually add on other therapies. But importantly, the exercise and physical activity was a part of that base model. And we see this is really drawing a lot of evidence that we see out of people that use exercise for the management of clinical depression, and some promising early results in terms of the use of exercise for men with prostate cancer. I think really importantly that, men, I'm not going to have a man bash here, but men are, typically reluctant to engage in psychosocial health and healthcare in general. And I think it's really important that we don't just force on our health system on guys, and we start to tailor the way that we're targeting psychosocial health for men, especially men with prostate cancer. And we think that exercise may be a very unique way to do this. It's a way that guys can engage and get peer support and actually have physiological benefit without having to engage in something that they may perceive as being feminine. So exercise in this way, it allows guys to articulate with idealised masculine values. So for them to being physically, physically superior, to not have to talk about their feelings, to be stoic, to allow them to use resilience and be independent and control over what they do. And I think in that way, exercise, certainly in a group-based environment, acts as a masculised supportive care service. It's action-oriented. They're doing stuff. And not only they're doing it in a casual environment that it's not necessarily about their mental health, it's about their physical health. And it's a positive, great environment for the guys to be in. Certainly we see that this kind of environment allows guys to use humour in a way that opens the door to difficult conversations and shuts that gate when necessary. So I think along with the camaraderie that comes with that kind of team-based environment, this may be a way that we can really tap into addressing mental health issues in men with prostate cancer. Certainly when we ask the guys about this, I think this supports this theory. This was a qualitative analysis of 12 guys who were involved in our programs for an average of 6 months. And we really just wanted to ask them what their experience was of a supervised group-based exercise intervention. And again, a thematic content analysis to try and capture what the guys were experiencing during this intervention. And you can see here, this kind of summarises the results into 3 main streams. That received health benefits, and you can understand the physical health benefits, of course. It was quite strong in terms of the mental health benefits that the guys were talking about. The support from the exercise physiologist was key in terms of getting these health benefits, because they were really seen as an expert and they could provide a lot of education to actually allow the guys to engage in that exercise and know that it was safe for them. But beyond that, it was also about being a support provider and engaging in that relationship and having empathy for the guys, and that was really important, and the guys articulated that quite significantly. We saw the third really pillar here was the ability to use this group as a means for peer support. They talked about having the shared experience of prostate cancer as being important, but it wasn't just that. It's the commonality, that stage of life issue. So they didn't have to just talk about prostate cancer. And I think that's important. It is important to notice, though, that there are lone wolves, and there was plenty of guys that didn't want to engage in that interaction. But those guys still said that they benefited from listening and hearing to those interactions as well. So I think this really supports the theory that we can use exercise as a way to engage guys in tackling their mental health. So to shift gears a little bit, I want to talk about some of our work in breast cancer. Much like guys with prostate cancer, there's a range of treatments that cause a series of different side effects. And these side effects are occurring at larger rates, or not the side effects, so to say, but because we're seeing more women being diagnosed and treated, and the treatments are effective, and these ladies are living longer, they have very unique healthcare requirements. I think one of the main issues that we saw early on was the management of lymphedema, and this was something that wasn't really being addressed well, and a lot of women were having some issues with it. There's a lot of literature out there in terms of saying, again, having a risk-adverse type of approach, and this was a few years ago in terms of not getting women who have lymphedema to actually engage in any kind of activity. And I think sometimes the support people can really facilitate this risk-adverse approach where the women shouldn't be doing anything, shouldn't be using your arm, you don't want to inflame the swelling or aggravating it. And this may actually be a counterintuitive kind of approach where you're trying to protect them, but you're actually having much more functional changes that are deteriorating over time, and certainly that the symptoms may become worse. So we were looking at using resistance exercise as a way to help manage lymphedema, and certainly to help gain a whole range of positive effects that we know that resistance exercise and certainly aerobic exercise is accountable for. So the first thing we really looked at here is this varying the intensity of the weights that these ladies are lifting. So the clinical guidelines is really avoid activity, which is counterproductive now, and it's kind of turned on its head. But if there was the chance that you are doing something active, that you want to minimise the load. And from an exercise science background, we know that a higher load will elicit more physiological adaptations and probably give more benefit in terms of the management of lymphedema. So we looked here in terms of actually comparing a high load resistance exercise with a low load resistance exercise on a range of outcomes, looking at the amount of swelling in an arm and the symptomology in the arm. And we saw that there was no difference between between a bout of low load resistance exercise, lifting light weights, or a bout of high load resistance exercise, lifting heavy weights. So there's no change from after that exercise, 24 hours after and 72 hours after that exercise. So building on this, we ran a randomised control trial actually looking at this change. Can we actually have women doing heavy weights, high intensity exercise, resistance exercise, and what impact does that have? You can see it's a 3-arm randomised control trial. We had women lifting heavy weights, women lifting light weights, and women not exercising at all. And we were looking over a 3-month period to see what was the severity or the changes in the severity of swelling and also the symptoms. So basically we didn't see any difference in terms of the women who were able to, or who were exercising with light loads versus the women who were exercising with heavier loads. We see these, this is symptom severity down here. We actually see the people that were exercising reported lower symptoms. And what I'm not reporting, and no difference in terms of the swelling. So the resistance exercise didn't inflame the swelling, didn't increase the swelling, didn't increase the symptoms, and actually had trends, and in terms of the DASH questionnaire here, significant differences in minimising the severity of symptoms. We've also looked at the impact of resistance exercise on inflammation markers, blood markers that can stimulate swelling after exercise. And basically this was just an acute crossover design with 21 women, and we're looking at a range of blood markers for inflammation here, and we're seeing across a whole range of different loads, low load, moderate load, high load. There was no significant changes in any of those inflammation markers, suggesting that exercise may not stimulate inflammation. We also looked at the ability of compression, and this is a big question for a lot of women. Should I wear a compression sleeve to minimise the risk of increased swelling and help manage symptomology when I'm exercising? Should I wear this? We saw that there was, you can see here, the top here this is lymphedema swelling with and without a compression sleeve, and we're looking at before an exercise bout, after an exercise bout, and 24 hours after an exercise bout. So both two different ways of measuring the severity of that lymphedema, and we saw no difference. So practically speaking, it's really, at this stage, we think that it's really for a women to self-select if they want to wear a compression garment or not during resistance exercise. To shift gears to a different side effect, cancer-related fatigue is probably one of the most common side effects across all cancers, and certainly something with radiation therapy that is quite relevant, not just during radiation therapy, but beyond radiation therapy. And this is a trial that we've wrapped up. We're currently analysing, looking at 100 women undergoing radiotherapy for the management of breast cancer. We've actually taken fatigue measures and physical activity measures serially throughout their radiation treatment and followed up to 12 months after their radiation treatment. And we're comparing between a home-based resistance and aerobic exercise program to usual care. And this program was really designed to be implemented in clinical practice, as you can see here, at a low cost, something that involves an individual consultation and then followed up with telephone consultations afterwards. So it's really allowing women to access exercise quite easily within standard practice and hopefully at a low cost. So we're seeing some pretty positive results for this, but that'll be coming out in the next little while. I think a really exciting trial that we've got going on at the moment is looking at the potential of exercise to prevent and counteract chemo brain. So cognitive changes brought about through chemotherapy, and we're specifically looking at women with breast cancer. So at the moment we've got 20 women enrolled in this trial. It's a randomised controlled trial involving supervised exercise throughout the chemotherapy, and we're following that up beyond the end of chemotherapy to see what's actually changing in women's cognition and their perception of their cognition. So a really important element that's not very well managed in our current practice, and I think, again, some exciting results to come. We're also having a look at the use of exercise for women with bone metastatic disease. So this is women with advanced disease. Now, differently to men with prostate cancer, these lesions, when they attack the bone, they're lytic lesions, so they degrade the quality of the bone. And this means that the rate of skeletal complications are much higher for women with breast cancer compared to men with prostate cancer. So again, in much the same way that we're working with the guys with prostate cancer, we're looking at, can we use exercise in a modular approach, so targeting areas that aren't affected by cancer, to actually help these women improve their overall well-being and quality of life. Another element that I think is really important and something we're not doing well in the field is actually looking at the use of exercise as a medicine to help improve function and quality of life and well-being with people with poor prognosis cancers. So these cancers, very low survival rates, very aggressive treatments, and these treatments can cause debilitating sequelae. And these side effects and these changes aren't common to what we see with these, the breast and the prostate cancer and the colon cancer that's researched quite rapidly. So this is very specific in terms of tailoring our exercise prescription to counteract a high level of unmet needs that's very unique and specific to people with poor prognosis cancers. So the work we're doing with that is really highlighted by the work we're doing in brain cancer and high-grade brain cancer. And I put this up here just as a theory. We're suggesting that exercise may play a role here, and it may play a role in terms of counteracting the side effects, not just physiologically, but also cognitively and emotionally in people with brain tumours. And we're drawing on the evidence that we're seeing in other cancers here, and then we're trying to apply it in a way that allows us to really meet these unique needs of people with brain cancer. So simple issues such as changes in balance, peripheral neuropathies, the ability to actually drive and get to exercise and do exercise is really different with these guys. So again, it's really chipping away at that targeted exercise prescription. So we've been working with St Charles Gardner Hospital in WA on a pilot study. We've got 30 patients who are going through their combined chemotherapy and radiotherapy, actually exercising at the hospital. So they're exercising 2 to 3 times a week during that 7-week period, and then exercising out in the community for another 7 weeks after that. And we're seeing some really quite remarkable changes with these patients over that period of time, and I think it's exciting in terms of what this means, especially for people, for example, on corticosteroids and dexamethasone. So those changes are quite very pronounced in terms of what's happening to their function, their body composition. We've also been looking at patients with pancreatic cancer. So one of the poorest prognosis cancers, very rapid changes in function and body composition, and can we actually use exercise to help delay those changes and maintain their functional ability for as long as they can? We published a case study on this showing very promising results in terms of improving functional capacity, fatigue, body composition, and then that translating over into quality of life improvements. We've currently got 10 patients enrolled with this trial, and this will be ongoing over the next couple of years as well. So I think really importantly, we've got this evidence now, and not just from, this is just our work, but from a whole field of research showing that exercise can be effective in helping to manage many of the side effects of a lot of cancers. And we even have guidelines saying that every cancer patient should avoid inactivity and should be physically active as soon as possible after and during their cancer treatment. But the stark reality is that the majority of cancer patients aren't exercising. Results or the research suggests that about 70% of cancer patients are not physically active enough. That's usually aerobic exercise. There's really no good data about the prevalence rates of resistance exercise, which we see a lot of very specific outcomes coming from resistance exercise. So despite this evidence, we're not actually making a difference in terms of standard practice, and I think it's really important that we focus our work here. And indeed, we've been working for quite some time to try, and through a number of avenues, to try and chip away at these changes. So I've been working with Cancer Council WA over the last 5 years at a community-based exercise program. So this is really translating what we know from in the clinic, in the hospitals, in a tertiary setting, out in the community. Can we engage normal fitness centres, standard fitness centres, exercise physiologists within the community to work with cancer patients, and what is the impact of such a program? So we've been running this across 15 clinics in both metropolitan and regional WA. It's subsidised by the Cancer Council. It's a 3-month supervised exercise program where the EPs are upskilled specifically in working with cancer patients. And it's only a small course, but it's something. We've been running an evaluation on this and seeing that it has indeed been quite effective in terms of making changes to physical function, quality of life, fatigue, psychological distress. It's a very rich data set, and I'm just talking about general trends, but there's, I think, a lot we can learn about actually how we implement these programs in the community, what kind of impact they can have, and specifically then how do we start tailoring these prescriptions so that we can provide people not only with evidence-based exercise, but affordable exercise that's accessible within the community as well. Now, along these lines, I think it's really important that we increase the ability of patients to access specialised expertise in exercise. And we've been working, this is a professional development course that I've developed and been running over the last couple of years. It's a small course, but as I said, it's online modules and then a practical workshop that actually allows exercise physiologists to upskill a little bit in cancer. So I know there's many EPs in the room, but for those who aren't EPs, cancer is a very minor proportion of the education of exercise physiologists, and there's really not a lot of specialised expertise available in the community. So this is something we have to work towards. I think this goes hand in hand with access to exercise facilities, and it needs to start in the cancer treatment centres. Now, and indeed in WA, I've been working really hard to try and capture unused space and turn them into exercise clinics. And this is what we've done here at Genesis. This is a radiation bunker that hasn't yet got a radiation machine into it. So we've retrofitted it into a gym, and now that's running in everyday clinical practice. There's a space here in Sir Charles Gardner Hospital within their newly developed cancer centre where we've just kind of commandeered it and thrown a whole bunch of equipment in there, and again using that in everyday practice. So these are the type of things we need to keep going and growing. And certainly then not only access to these facilities and expertise, but access to information. Not just patients and their families, but the oncology team, general practitioners, exercise specialists in the community. This is something we need to work towards, and something that I certainly spend a lot of time doing as well. Another way that we can do this is actually engaging with our peak professional associations, and I'm absolutely stoked that we've got so much momentum within our Clinical Oncology Society of Australia. We've established a newly established cancer and exercise group. So this is exercise having a seat at the table with all the clinical oncology professions in Australia. And I think that's really important in terms of what we can do in terms of advocating for more access to care, for more education, for more awareness about exercise in oncology. And on the flip side, within Exercise and Sport Science Australia, we have an exercise group that we've developed this year, and it's gained a lot of momentum in terms of upskilling and capacity building the exercise physiologists within the community in terms of how we can actually get patients engaged with our programs. So I think really important that we're not only doing the research but trying and working towards efforts to translate this into practice. So very briefly, I just wanted to touch on, I think, where we're heading in the next couple of years. I'm absolutely thrilled to be here in Melbourne, and it's so fantastic to be working at such a dynamic and interesting place as the Institute for Health and Institute for Health and Ageing. And I think there's a lot of really exciting things that we can do in the coming years. Certainly from our perspective, our team here will be continuing to strive for transformative research. So research that really makes us think and changes the way that we're approaching the management of side effects and indeed the management of cancer-related effects, specifically in people with cancer. And I think it's really important that we really target this to areas that aren't being effectively managed with our current strategies. There's a whole raft of ideas and areas we can go within this, but I think it's really important that we start chipping away at symptomology that's not effectively managed. And then implementation research, how can we implement this? How do we combine our interventions so we have really truly integrated care? What impact does exercise have on cancer prognosis, on cancer biomarkers? And the list goes on and on and on. Certainly, again, as I mentioned before, targeting patients with high unmet needs and areas that are relatively understudied so we can generate new knowledge. For me, my approach is all about collaborative, multidisciplinary approach. I think this is so important in actually asking the important questions and having a crack at answering them. And this is why I'm so excited that there's so many people here today. I'm absolutely rapt and really looking forward to the potential of working with you and hearing your thoughts about how we can move the field forward. And I think it's not just about generating new knowledge and generating new knowledge through innovative research, but it's also about how we effectively translate this into healthcare policy and practice that makes a meaningful change in patients' access to care and their quality of life. So I hope today that I've given you a little bit of background about what we do and some of the research that we've done, and certainly where we're heading in the next couple of years. So before we all get down for a nice drink, I'd be very happy to answer any questions anybody has.